Mike Gibson, Stefan Anker, and we're talking about patients with chronic heart failure and iron deficiency and a new therapy, ferric carboxymaltose. Stefan, talk to us about what you did and what you found.
Well, thank you so much for having me, first of all. What we did is something that actually I planned 15 years ago, right at the end of the FAIR-HF1 trial. I spoke with some senior people, including from the New England Journal, what would it take to get another New England Journal paper on the iron story? And the answer at the time was simply, well, get us a morbidity and mortality trial. And of course, we tried to get the funding. It took more like 5-6 years to get that funding. There were several other initiatives going on. And of course, you know that with our trial, we are not the first because several trials reported in the meantime, but maybe we are the last of the big trials for quite a long time to come. And we report on 1,105 patients in the study with heart failure and a reduced ejection fraction below 45% EF. Having iron deficiency, we randomized them to ferric carboxymaltose compared to a control. Our study was blinded, which is a difference to quite some others, and followed them for 1 year and 3 quarters, and basically looked for event reductions in this trial.
And what did you see?
Well, in this study, of course, having this long duration, having seen in the meantime, when originally we wanted to have recurrent events analysis as the primary outcome, we saw in the meantime that basically time to first may even give you some more power, gives you at least as good, if not more reliable results. So we changed the primary endpoint to actually 3 primary endpoints. The first primary endpoint is cardiovascular death and heart failure hospitalization time to first event. The second one is recurrent heart failure hospitalizations alone, like for instance done also in the co-op trial and the FAIR-HF2 trial, really focusing on the one item that has already the guideline recommendation in many places. And the third one was a little bit of an innovation. You know, over the last 12, 16, 18 months, there was a strong discussion that the better definition for iron deficiency is not one where you use ferritin and TSAT together, but where you simply say transferrin saturation less than 20%. So the third primary endpoint was the time to first event of CV death and heart failure hospitalization in the patients with a low transferrin saturation by definition alone. Well, the short version is we have about a 20% reduction for all these endpoints, 21, 20%. But by the rules of our trial, where 3 endpoints had to be below 0.05 to be significant, 2 of them had to be below 0.025 to be considered significant, or 1 of them below 0.0167, I have to say that formally, none of them reached this level by itself. The CV death and heart failure hospitalization for the whole population, 21% reduction, had a p-value of 0.07, sorry, of 0.038. Can you cut this somehow? So the cardiovascular death and heart failure hospitalization first primary endpoint for the whole population had a p-value of 0.038, formally, unfortunately, not significant. The recurrent heart failure hospitalization had a p-value of 0.07, again, about a 20% reduction. And the subgroup was simply showing identical results to the whole study, like a 19-20% reduction of event rates, but the p-value was 0.11. So none of this was formally significant. Now, the results are very much in line with the previous trials, which of course automatically means what about a meta-analysis? And we did a meta-analysis, and the results of that are, first of all, significantly positive. Second of all, just accepted. The primary study, FAIR-HF2, is accepted in JAMA, but the meta-analysis is now also accepted in Nature Medicine. So this is all coming out at the ACC time. So this is really good news. Now, there is one aspect of both studies that is really most interesting, and This has to do with the dosing of the treatment. Now, when you give intravenous iron, you correct an initial deficit and you give about 2,000 milligram at most, on average, like 1,500 to 2,000 in the whole year. But basically, you need to do this over 2 sessions in the beginning mainly. And by the design of the trials, our trial, but also previous trials, the dosing you're giving in the second and the third year is much less. In our trial, about 900 milligram in the second year, in the other trials, 500 milligram. And it appears that when you give more, you get more benefit. In the first year, the reduction in the trials, in our trial alone, in the meta-analysis, are clearly significant. We are talking then about a 25 to 30% reduction in events in the first year. And then you lose this benefit over time simply because you give less iron, things come together. And I think that leaves to me the main unanswered question is, should we give more iron in the second and in the third year? So this is the most interesting thing. And then the second interesting thing is our trial in itself with 1,100 patients didn't show very convincing subgroup results, more or less nothing dramatically showing in one or the other direction. But this is what you have a meta-analysis for. And there is 1 out of 8 subgroups that we could analyze in 6 trials together. And these 6 trials have 7,175 patients. 1 out of 8 subgroups that basically showed a very significant interaction. And that's interestingly something that many people will find very politically also interesting. Women don't get benefit for events. Men get a very strong benefit. Women, from an event standpoint, not at all. And we have no idea why. And this,
Interesting. Was the can you look at an interaction term in the meta-analysis? Was it positive?
Yeah, we did. It was strong. It was strongly significant, different. There was really a big difference. The effect size in women for events, cardiovascular death and heart failure hospitalization was essentially a hazard ratio of 1.00.
Wow. Wow.
Nothing. And in men, basically, you have a 25% benefit.
Wow.
And so this clearly is very significant. For all the other things discussed, anemia, yes, no, ischemic etiology, yes, no, having a transferrin saturation that is low or not, when you have a little bit a sicker population, you get a little bit of a more benefit in terms of numerically speaking, but nothing significant at all in terms of the interaction terms, not at all significant. It's just that if you have a little bit more events, you can, of course, also get a little bit more benefit because you have more shall we say, mass to change. But in terms of significant interaction, absolutely only men versus women. But one important thing, that is not the case for symptoms, quality of life, or exercise capacity. So that's not the case for safety. So the treatment is absolutely safe. If you take all the trials together, we have for cardiovascular death, about a 10 to 15% reduction, for all-cause mortality, 8 to 10% reduction. Not significant, but good trends. But very safe treatment overall. Yeah, and some stimulus for further research, I would say.
Stefan, where do you see this now fitting into guidelines with your meta-analysis? Where do you see it coming and landing in terms of recommendations?
Well, we need to really see what the guidelines currently say. They say there's a strong recommendation for symptom quality of life improvement. And there is a recommendation to use it also to reduce heart failure hospitalizations. Now, these recommendations were technically speaking made before the HeartFit trial came out. And that trial was basically much bigger than the others before, but had neutral results. Or shall we say, results that really were very unimpressive. Small trends, more or less neutral. Now, there were basically a number of people thinking we should now downgrade the recommendation for iron. And I think that with our new trial, 1,100 patients, 20% benefit for the event's outcome, plus the meta-analysis, showing this dimension of benefit for the whole 7,000 patients in total and showing also clear statistical significances. I think this is reassuring the guideline writers and the medical world that these recommendations that were already there before HeartFit can now, after HeartFit and FAIR-HF2, they can continue to be as they are. Pretty good recommendations. We do not need to downgrade them. We can absolutely keep them, I think, as they are.
Stefan, thank you for joining us today. Thank you for sharing. And thanks to all of you for joining us here live from ACC 2025. Thanks.
Thanks so much.